Welcome to A Capital Conversation, sponsored by Capital Caring on WTOP and WTOP.com. I'm your host, Jason Fornicola, and my guest today is Maylene Davis, President and CEO of Capital Caring. Maylene, welcome to the program today.
Thanks, Jason. It's good to be here.
Let's establish what hospice care is and why it's such an important part of a person's care.
You know, a person goes through many chapters of their life, and we come into this world and then someday there's an exit. And so hospice and palliative care, Capital Caring, is taking care of patients and their families, because no one ever goes through this alone, hopefully, through a very advanced illness time. They've gotten a diagnosis that does not have a cure. And so they are going through either treatments or surgeries or the like. And essentially, they have decided that they would really like to spend as much time as they can at home, and wherever they call home. It could be a nursing home, it could be an assisted living, it could be a friend's home or their daughter's home, it could be wherever they call home. And essentially, we are caring for about 1,200 patients a day in their homes in the greater Washington, D.C. area, Northern Virginia, Prince George's County, Maryland, and the District of Columbia. And we do that by sending out doctors and nurses and social workers and nursing assistants, and there's a big volunteer program. And whatever patients are assessed that they need, and they're telling us what they need. So it's what matters most to them is what we're working on, with the priorities really being around pain control, pain management, and symptom control, and helping people achieve their life attainable goals for the days that they have left. So we say they have more yesterdays than tomorrows.
You mentioned one of those key pieces as being pain control and pain management. How do you go about achieving that for someone at a stage of advanced illness?
Well, it's very interesting, and it's probably the foundational question, and that is that we go about it by making sure that everyone who touches the patient, visits the patient, crosses over the threshold into their home, is asking about their comfort level. And so whether it's to the chaplain that we send, or the nursing assistant, or the social worker, or the physician, everybody is inquiring about, how are you feeling? In fact, we take it so seriously that we actually have a telecaring program that we do that pushes out outbound calls up to twice a day, 7 days a week, to our families. And the calls end up being very short, maybe 2 minutes, but just say, how'd you sleep last night? How are you feeling today? And so we're always gauging how the treatment, how the medications are working, because if they're not, then there's a myriad of other medications that we could try. So we are, and all of these are going into our database, into our electronic medical records. So we're always talking back with the patient's doctor or our medical director to, decide on how can we tweak this to make sure that people are getting quality of life, that they're comfortable, that they're getting time with the people they want to be with. We all have, we talk about the bucket list. It's the things that they want to get done. Well, people, even with advanced illness, have the bucket list, things that they want to do. And so we're really trying to make a plan of care that helps them attain and achieve those goals.
And in what ways is this approach different than perhaps what has been done in the past, or maybe the way things still are done today?
Well, there are about 4,300 hospice programs in the country, and I would say that every charter of every program talks about the main goals being pain control and symptom management, because we know that people cannot get what they need to do done when they have pain. It's, everyone has experienced some sort of pain in their life. And if you have a bad headache, just help me alleviate this, and then I can get to my next work or my next task that I need done. So that's always been a part of what hospice is since it came into this country in the late 70s. And Capital Caring, of course, was one of the pioneer programs in the country. In the late 70s, it was called Hospice of Northern Virginia then. And our hospice medical director at that time was a little Filipino Dr. Josefino Magno. And she was the national medical director, because how hospice was created, Hospice of Northern Virginia was part of that. So a lot of people across the country would come in and through Hospice of Northern Virginia in the 70s and the 80s, and still today. and really see how we do things, how we approach these things, and they would write it all down and go back and do it in their communities. And we were always happy to do that because we really have always had our eye on quality. We drive with quality, and that's why we measure how people are doing, how if they have shortness of breath or pain or any symptom out of control, we're looking at that. Most people, when they've been on hospice for a little while, say they wish they would have been on hospice a lot sooner. It's probably the number one complaint that I get in my office is that why didn't my physician tell me that this was available, because we could have used this months and months and months ago.
In order to be effective for so long as you have been as a company, obviously innovation must play a part in that. How have you been able to keep current and even a step ahead of the other practices that might be happening?
Well, I think that we do have the luxury of having a lot of community support here in the greater Washington, D.C. area. So that we have a lot of people who donate money, which allows us to do a lot of extra things that you wouldn't see in your everyday hospice program in America. And so, for example, the telecaring program, is a good example. We really felt that after we had asked patients and their families, are you confident when we're not there and you're doing this by yourself? And most of them across the country, hospices were asking this. It was a national survey. People were saying, no, we're not that confident. And so we started talking about this at the office, and I said, I really want something in place to so that if we're visiting Mondays and Thursdays, if people are really feeling scared on Tuesdays and Wednesdays, I really want to know that. So I said, why don't we start calling folks? And the next thing you know, I asked my board of directors if we could do it, and they were like, absolutely. And so we used our philanthropy money to start this telecaring program, and twice a day. And wouldn't you know it, in some, people went to the hospital less because we were always gauging what they needed on a daily basis. So even though we went on Monday, we call on Tuesday and they need something, then we would respond on Tuesday instead of waiting until Thursday. And so it became very scientific. And we had a gentleman that actually told us that the telecaring person was the only person on some days that he actually got to speak with, because his wife had Alzheimer's and she wasn't able to speak. And it really just touched your heart, because he said, I really look forward to this calls because that's the only other human that I'm talking to. So we do that. Pain control and pain management have always been very important to us. We actually have 20 full-time physicians that work for Capital Caring. They're all board certified in the subspecialty of hospice and palliative medicine. We also have 14 nurse practitioners who are also board certified. So, and plenty of our registered nurses have sit for the national exam, and so they really are experts, if you will, although we always consider ourselves serious students. But certainly, we have last year opened up a center for pain and palliative care. And the center is it's the only hospice that I know, we're the only hospice that I know that has such a thing attached to it. And we actually opened it up. We recruited an anesthesiologist, a pain doctor from Emory University, and he is, we have a C-arm, we do it under fluoroscopy, so we are actually, we really believe that if there's not something that you can take by mouth, that perhaps you might have an illness, that perhaps an injection of some sort, a block, and people would be familiar with an epidural, because mothers get that when they have babies sometimes. And so, and it's been miraculous. I say their tagline should be, people are being wheeled in and walking out, because it's just been amazing to see some people that have just sat there in the recovery part of it and just cried because they thought, oh my gosh, we're like, what's wrong? We're like, this is the first time my wife's been pain-free for weeks. We haven't gotten sleep for days and days and days. So my folks are really, on it. They really focus in on what matters most to you, and how can we help? Maybe you're worried about your checkbook, or maybe it's medicine or whatever. So
how does that make you feel as someone who, and you and I talked beforehand a little bit about your personal experiences in this, how does it make you feel to see and hear those kinds of responses from your patients?
Well, it really takes me back, Jason, because my dad was a hospice patient back 10 years ago, and I was the president CEO in West Virginia at that time. And I had been working for hospice for 15 years, but here I saw it rolled out in my mom and dad's living room. And I remember taking one of the CNAs aside, and I said, "Now, are you doing something special for us? Are you sure this is what we do and everybody's home every day?" And they said, "Maylene, this is what we do every day." And I thought, this is the best thing next to sliced bread. I don't know what we would do without you. And it's amazing. So I think that, because it's so personal, it's your home where this is happening. This is, your sanctuary. This is your home. It takes a lot of trust to allow someone to come into your home, a stranger, and get to know you. But the key thing about hospice, as opposed to other entities in the healthcare continuum like hospitals and home health and things, is that we assign a team and they're with you the whole time that you're on hospice. So whether that's 3 months, 6 months, a year, however long you're on hospice, you will have the same team. So you do get this level of familiarity and trust with someone, and that means a lot to folks, and quite honestly, our folks even go to the funeral homes and visit with the family, and they just stay in touch. We do have a bereavement program, which is another thing that kind of is very unique with hospice care. And so up to a year after the patient has died, then we stay in touch with the family to see how they're doing. We offer support groups, one-on-one counseling, bereavement camps for kids, because death touches all ages. And we are actually one of the only hospices in the area since the beginning that have cared for kids. And we care for about 75 kids a year. We work very closely with the children's hospitals in Virginia and in DC. And it's a wonderful relationship, all of us kind of working together when a child is involved.